start by just orientating you to your environment and your patient today, and then I'm going to start by giving you a STEM, and we're going to start with you, Dr. Azhar and Ella, by looking after the patient. Sujata, you're going to be outside the room, and I'll tell you when to come into the room, and we're going to look after the patient. So I'm going to just systematically take you through this.
Okay.
Ella, are you familiar with this monitor? Are you happy with the monitoring and attaching that?
Yes, I'm happy with the monitor.
Okay, so you've met this before. Fantastic.
Will it be bleeping?
So this will make sounds and bleep. If you want to do the blood pressure, you can activate it by touching there, so it works like one of your monitors in the screen. In terms of your resources within here, we've tried to model for you what you might see in your emergency department, and so all of the resources and the drugs are here. If there is something specific that you can't find, this is not an exercise in finding worry. And so if you can't find something, you can ask me, and we will try and find and provide you with a resource that you need. Okay? Everybody happy with the environment? So the one thing that I will emphasize for you, this is very different from what you might have encountered in resuscitation courses before. If you're going to give this patient a drug, I expect you to cannulate the patient, and I expect you to physically give the drug through the cannula.
So real time.
So real time. Okay? And unless you do that, the patient won't respond as we need to. So let me just ask you, have you met a patient like Vijay before? Have you guys seen the patient? You have? Yeah? You have. Okay, so let me take. So I want to just from the top end just orientate you to this patient, because I know sometimes it can be a little bit strange encountering. So you might notice that Vijay's head is moving, and this particular type of simulated patient has the facility to seize, and so that's what a seizure looks like in this particular patient. Okay, so if you see that, that implies that this patient is having a seizure. You'll also notice that the eyes don't open, but you can open the lids. And so though the pupils are not reactive to light in real time, I expect you to perform that action, and I will give you the feedback about what the pupillary responses are. Okay? In terms of the airway, both the nasal airway and the oral airway is fully instrumentable as you would a clinical patient. And so if you wanted to intubate or augment this child's airway, you can do that through this facility. Okay. From the chest point of view, you might notice that his chest is moving up and down, and so we expect you to get the respiratory signs from examining the patient. You can hear breath sounds and heart sounds in the front of the patient. Be aware that in the axilla, where we would normally listen, you won't hear things because there's no speakers in that area. And so if it sounds quiet in the axilla, it's not a pneumothorax. Listen to the front of the chest.
Okay.
It's something that often
confuses. Focus on the front of the chest.
Focus on the front of the chest for the sake of the scenario. The abdomen is pretty featureless, and so as you palpate it, you won't feel the liver. However, if you feel that's important for your scenario, you can do that, and I will give you feedback. Okay? In terms of the cardiovascular system, I'd like you to feel the carotid pulses. Pulses are palpable in both carotids and in the left arm, so both the brachial and the radial. Do you want to just have a feel and make sure that you're happy with what they feel like?
Yeah, I can feel the radial.
Okay,
Yes,
you're
I
happy
can feel
with
the carotids.
Okay, fantastic. The right arm.
The carotids too.
Fantastic. The right arm is what we call the IV arm, so you cannot feel pulses in this arm, and that's purposefully in the design of the mannequin. So this is the arm we expect you to cannulate. And equally, there are no femoral pulses palpable in this particular patient. Okay, everybody happy with the features of this patient?
Yeah.
Okay, so I'm going to introduce to you this patient. So Sujata, I wondered whether you might leave the room at this point so that I introduce him to, and we'll call you in later. Thank you. Okay, Azhar and Ella, so this is a 5-year-old little boy who's called Vijay, and he's known to have developmental delay. And his father, who's with him, if you wanted to step closer down, his father's with him, has brought him into the hospital. And what I'd like you to do is start at the point where this patient has arrived. You can ask the father for a history, and he will give the history to you. But at this point, I want you to assess the patient and escalate the care of the patient as you would normally do. Okay, so 5-year-old boy, we can estimate his weight at 20 kilograms. Okay, everybody happy with that? Okay.
So, Dad, my name is Ella. I'll be looking after him.
Vijay, someone can please check this baby. He has fever from last night and he's fitting.
Sister Ella, can you just attach the bed?
Yes, I'll just get
Please do something.
We'll take care, just wait. We'll take. Speak loudly. I'm not able to hear. Speak as loud as possible.
Vijay, can you hear me?
No, he's not responding this season. We'll attach some oxygen for him. Just pass on the mic, they're just not able to follow it.
Okay, so does he have a patent airway?
Yes, he's having a patent airway, so we'll just attach the oxygen
Okay,
presently.
let's get the saturation on. Got the monitoring, 119 is the heart rate. Okay. Saturation monitors on, heart rate's 120. Okay, so with a heart rate of 120, the saturation's 94. We've got some
Okay.
oxygen on.
He's still seizing.
Would you like me to get anything?
We'll put an
What's
IV
happening,
tag.
Azhar? What's happening?
He's a 5-year-old.
Is he seizing?
Yes, ma'am.
Okay. Can you get an IV line, Azhar? Can you get an IV line? And give midazolam, what he looks like, some 20 kilos or
Ma'am, yes,
something.
please take care of
So
him.
just give 20 milligrams of
Will he be okay, ma'am,
midazolam.
please?
He'll be okay, sir. Can you please wait outside?
Yeah, but he's like not breathing.
Yeah, he'll be fine, sir. I know he's fitting. Can you please wait outside? We'll come back and actually I'll talk to you in detail. So have you got the IV line? Can you check the blood sugar also, please?
The glucometer went to biomesh. Sorry, it went to be calibrated, the glucometer.
Okay, we must make sure that it's available, you know. We are having seizures, children. Okay, so what do we have?
IV line is in
Looks
place.
patent. You've got the IV line, you
Yes.
can't check the glucose. So Sister Ella, can you just make sure that you give midazolam, please?
So 20 milligrams of midazolam, yes?
Yeah. So I'll come back and talk to you, okay? So we've got the airway that is patent. He's breathing, saturations are 96%, heart rate is around 124. Let me feel the pulse now. Okay. And have we checked his blood pressure? That seems to be 123 by
Doctor, he's not
70.
breathing. Is he okay or
Just
what
expose
is
his
what
chest.
happened
Just
to
wait,
him?
sir. We'll take care
Just
of
please take
Just
care of
wait
him.
outside.
We'll take care.
Just
We'll
wait,
take
sir.
care, sir. Azhar, I can see the saturations are dipping. Can you get the bag, please?
20 milligrams of midazolam has gone in.
Okay, midazolam is gone. Let us just sort of get the oral airway, get the bag, please. Okay, so let's start bagging. Okay, I can see good chest movements there. Let's see if the saturations are picking up. Okay, they are picking up. We feel the pulse here. Okay, so saturations are picking up. Okay, probably it's just gone into respiratory arrest following that midazolam, you know. It's just so strange to happen right away.
Heart rate is going down.
Okay, probably it's a good idea to just get our intubation ready. So can you please get set for intubation? We'll get the laryngoscope. We'll
Okay,
get-
guys, thank you very much. I'm going to stop you there. Can I ask that you dispose of any sharps safely? The rest of the equipment you can leave as it is. We'll clean up afterwards. And what I'd like us to do is go through to the other room and go and debrief. So everything.
I felt really nervous. It was like the real situation.
Can we say who is the team? Who
Yeah.
was the consultant? Who was the nurse?
Who was the team leader?
Okay, well, hold for that. But let's identify at least what your role was clinically.
So I was the nurse.
Okay, up there.
I was the ER consultant.
ER consultant,
I was the junior resident.
junior resident, and our faculty. Okay? So we leave there. Okay? Let's re-engage in the debriefing.
How was your experience with that?
I don't know, this is just a common scenario that I routinely see in practice. And this child came in with seizures, and we saw that the child was still fitting, and we gave midazolam. He had respiratory arrest. We started bagging, so that's what happened.
How did that feel? It was a very real-like situation what we see in the daily ER life. So it was good. It was a learning experience.
So this case was a 4-year-old child weighing around 20 kilos, a known case of seizure disorder, who had fever for 1 day, and he came with seizures for 30 minutes. So this was essentially a case of status epilepticus. I will request David to take over the debriefing and then discuss about the management of status epilepticus.
Okay. So I wanted us to I wondered whether we could just review how we managed this patient and the things that we did as we were in there. So Sujata, I wondered whether you could start by talking us through just how we managed that patient scenario?
So I just sort of walked into this scenario. I saw this, what looked like a 5-year-old child, probably 20 kilos, and I just saw the child fitting. I'd seen that Dr. Azhar and Ella had actually put the child on the monitor. I also saw that they'd connected him to oxygen, so his saturations were normal, but the child was still fitting. And I just wanted to make sure that we get on with it and give the medications. So we asked Azhar to put a cannula in, and unfortunately there was no blood glucose available. We went ahead and gave the midazolam, and subsequently the child did have a, just became apneic and desaturated. So we got on with it and, did back and mask ventilation. And we were getting ready to intubate because Ella reminded us that the heart rate was also dropping, so I didn't know whether this was going to continue for long.
So, I wanted to say thank you very much. I think that's the patient as we said. So can we just review, so how much midazolam did we give the patient?
The child was 20 kgs. I don't remember, what did we say?
We gave 20 milligrams of midazolam.
Okay, interesting. So for
Just pause for a minute. This microphone's not working, I don't think. Can people hear David?
No, we can hear.
Okay.
Hear me?
I just feel like it's...
Okay, so you hold that. I'm fine. I'm glad. So let's review. So 20 milligrams on midazolam.
20? Did I say 20?
I think you did say 20. It seemed like a lot when I drew it up in the syringe because I had 2 syringes full and there was 10 milligrams in 10 mils. So that's 20 mils I gave.
That's a very large dose. No wonder the child actually had a respiratory arrest. I just can't understand. How could I do that?
Right, okay. So that's interesting. So Ella, I noticed that what you said is that, and I actually observed that during that scenario you asked about the dose several times. And I wanted to just check with you, so on looking at that, if people can hear me, that's fine. Can all hear me?
Yeah.
So what I just wanted to check with you, is that correct? Did you have some concerns about the dose of midazolam?
I did have concern because of the volume. It's a concentration I'm not familiar with, but when I actually drew it up and did a bit of readback of 20 milligrams, I was quite convinced that was the dose that the doctor wanted to give. But I was concerned because of the volume, and it's not a dose I would normally give to a child that size.
Right, okay. So I think that was my perception, certainly. So let me ask you this. So how is it that despite the fact that you clearly had concerns about this dose of midazolam, as you have identified, and for all the reasons that we might expect in this patient with a risk of such a large dose causing apnea and potentially requiring intubation as this patient had occurred, how come, despite the fact you clearly identified, you didn't speak up and voice that concern to the rest of your team?
There was a lot going on, and to be honest, I was quite nervous. I haven't been in the emergency department that long, and I've done a lot of paediatrics, and I didn't want to question somebody so senior who was really quite assertive in the fact she wanted 20 milligrams. So I was probably a bit nervous to question somebody at that degree of seniority, being a nurse.
Okay. So let me see if I understand you correctly. What you're saying is that because of this perceived hierarchy or seniority within the system, you felt uncomfortable expressing your concerns. Is that correct?
I did, and I did clarify the dose as well. I did say 20 milligrams. I felt that I was displaying feedback and closing the loop, as to speak.
So let me ask you guys this. Have you ever been in a situation where, because of a perceived sort of hierarchy within the system, or that you felt that you were unable to speak up?
It happens for quite a lot of time. That's when Siddha says something, we have to do that. If you question, there might be some consequence.
All right, that's interesting. So this seems like it's something that you, well, from what you're saying, it happens. Okay. All right. So let me. Sujata, have you ever been in a situation like that? I guess you're at the senior level now.
I have so much distractions usually as a senior, and it's important to actually compartmentalize things. So, you know, in this situation, I just walked in, I wanted the seizures to be in control, and, you know, and we had the father kind of walking in and out, and so that just kind of distracted me. But I do recollect kind of Ella asking me, but I was just so focused on the father that, and focus was just to control the seizures, that I probably just sort of got distracted.
So I'm just going to, I'm pausing the play for a moment. I'm just pausing the tape. Everyone's freezing. But I want to highlight what just happened. We went from an individual, right? The conversation was with Ella about something she had done that he wanted to explore. And then David did a very important pivot, a very important move in this methodology, is he then generalized the discussion to making it not Ella's problem anymore, but it's now our problem. And we're looking at it from different perspectives. This idea of not speaking up. Why does it happen not just for Ella, but why is it our problem? And it's relating to this idea that it's a human factor. It's not an Ella factor, it's a human factor. So let's talk about this phenomenon, and let's try and sort it out. So that's where we are right now, and I just wanted to put a big glowing halo over this, because it's going to be a lot of the methodology is going to be about how do we take it from the individual and talk about it in a general way. Specifically as it relates to goals and objectives relating to team factors. Because often where the team falls apart is about elements, things that force us, that are about human factors, that we are all susceptible to. Does that make, I want to make sure, so that's the pivot that just happened, and that's critical to the methodology related to teamwork training. I'm going to send it back. Release the pause button.
So Suja, that's okay. So what I heard you say is that actually, as a senior person, quite often for you, the fact that people around you sort of challenge you is useful because often you're thinking about multiple things. Is that correct?
That's correct, yeah. I mean, probably when I did give the answer of 20 milligrams, I would have probably kind of, you know, maybe it would have been a good idea if Ella felt that the dose was not right to actually cross-check with me and get my attention fully.
Okay.
Maybe that would have saved.
So interesting. I'd like us to move on then. So this seems to me like it's something that's a common problem for us at a junior level potentially because of this perceived hierarchy. But more than that, it's something that actually, from the seniors' perspective, it's important for us to get our team around us to help us keep us safe. So let's think about how might we address this problem? How might we, in future, if we came across this, what strategies have you guys used in the past, that this is something that happens so commonly to you, to address this? How might we prevent this from happening again?
I think what I would probably do is express my concern and actually say to maybe Dr. Azhar and ask him also, is this 20 milligrams, shouldn't it be 0.1 milligram per kilo? I've given 10 times too much, or I might give 10 times too much. So maybe I should have been a bit more assertive at the time. That would have prevented that incident. So I probably learned from that.
So this idea of speaking up loud and making sure that you get the person's attention.
Re-clarifying.
Okay. Anything?
Same thing. I should have asked question this senior consultant once again. Whether this dose looks to be too high. And recheck once again.
Okay. So let me. So what I wanted, Suja, sorry, did you want to?
I think from my side, probably I could have been a little bit more attentive. And actually, when Ella asked me, is this the dose you want to give? I do appreciate that there are so many distractions. I could have just paused it or attended or delegated to one of the other team members to check the dose if I was being asked again, or just tell the nurse again that, you know, maybe you should check the dose again.
Okay, that's a great idea. I want to share with you something from my practice that I found very useful, and it's something that I call the 2 challenge rule. So let me explain that to you. It has 2 elements. So for people like yourself, and I guess myself as a pediatric intensivist, I always say to my colleagues and my fellows, when anybody asks you a question twice, hit the pause button, as you quite rightly say. Because usually if somebody asks you a question twice, there's something they're worried about. And I always say to my nurses, tell me, because there's clearly something I'm about to do that I'm going to regret. So as a person in the senior position, anybody asks you the same question twice, force yourself to stop. From the perspective of the other side, the way this works is certain the first things that you might highlight, as you quite rightly did, Ella, asking concern, Sujai, are you sure that we want to give this patient 20 milligrams of midazolam? And here's the key: if on that occasion you don't get a response, or you find it, you don't get the response that you want or reaction to that, then the second part of this, and this is where the need bit is, often when as seniors when we get challenged, people don't tell us what they worried about. And so that makes it very difficult to interpret. And so the second part of the challenge is to say to that individual, Suja, we're about to give 20 milligrams of midazolam. I'm concerned that this is 10 times the normal dose for this patient. Are you sure we should be giving that dose? And make sure that you hold her attention. And what that does, it forces the senior person to reflect on that and think on what they want to do.
So I'm going to pause again, just for a moment, practice. And then he also has in mind something he wants to share about a tool that they can take away from this that will help them in addition to the strategies they've come up with. So always the group first, and then if you have some strategies that you want to share, you offer those up as well, if they haven't mentioned them. So that's where we are now. Generalized discussion into a solution and application piece. Okay.
Right, so I think the key things that we wanted to take away from this scenario is clearly that this is not, despite the fact that we run the scenario several times, and this is not an infrequent thing to happen with dosage errors when things are busy and concerning, particularly with a concerned parent or a distracting factor in that. And we talked a little bit about strategies that we might use in this. So let me ask you this, Ella, what is it that you're going to take away from today, if you want to just supplement?
What I'll take away from today is the fact that if I am concerned about a drug dose, and this is quite frequent in paediatrics in the heat of the moment, that not only will I be a little more assertive, but I will choose my words when I am questioning the dose and express my concern that it is 10 times the usual dose that we would give. So I think I'll take that away as a patient safety issue.
Okay.
It's an error that could have been prevented.
From my side, I think it's given an insight to say that, even as a senior, I'm vulnerable to making mistakes. And it's important that I acknowledge and listen to my team. Be a bit more sensitive to say that when somebody is asking a question, listen to it carefully or try to think, why is that question being asked? This may be a repetitive scenario for us, but it's just given an insight that, even though I'm a senior, I could potentially make these mistakes. And it's important to try and work out what strategies I can put in place to rectify them. And I think the two challenge technique is something important. Probably I should make sure that, I let my team members know at all times my strengths and my weaknesses also. And then they should feel free to communicate how well to focus on the child. It's not about the individuals.
Okay, I'm going to pause here. And then we're going to close the debriefing, but I want to just highlight and annotate the last two steps that David just did. So he moved from solutions into what we call the summary phase, which is, let's talk about what did we learn today. And I want to be very clear that this middle piece of investigation that we felt, where he started talking to Ella, started to moving it out to the team, we call that the analysis phase. It's the one right in the middle, and it's the one that you can scale. You can ask about, we can have one conversation about one topic, or we can have several conversations within that middle piece. We're going to learn about this over the next 2 days, so I'm just giving you broad names and ideas around this. Then he moves to the summary phase, and then he ends by asking the team, what are you taking away from this experience? In a way, giving the adult learner the last word in the debriefing. And that is a complete debriefing in its phases and steps. So, can I get a round of applause for our participants? For David and all the people who ran this.